Considering a career in radiation oncology, a guide for medical students. This presentation is brought to you by myself, Nicholas Sayorski, and Dr. Shauna Campbell. We are both at the Case Western Reserve University School of Medicine. This presentation is meant to help guide medical students in understanding radiation oncology and potentially selecting radiation oncology as their career. What is radiation oncology? It is a specialty that is focused on the treatment of the second leading cause of death, which is cancer. And about 2/3 of patients with cancer will receive radiation therapy at some point in their disease course. The most common cancers that are treated in radiation oncology facilities are those of the breast, prostate, lung, and rectum, as well as metastases. These are cancers that spread from the primary tumor to other sites of the body. Notably, the majority of patients with cancer will actually not die of their cancer, but rather of competing causes. What is radiation oncology and how does it compare to other fields, and why might you find it interesting as a career? Well, number one, it's a driver specialty. This means that you as the oncologist are making treatment decisions. Patients come to you and you, using your expertise, will decide if they may benefit from radiation therapy, the area that should be treated, the dose that should be delivered, etc. Radiation oncologists also have the most oncology-specific training out of all residencies. Radiation oncologists can subspecialize, so if you're interested in women's health, genitourinary cancers, gastrointestinal cancers, etc., you can focus on just that type of cancer. The specialty is multidisciplinary. This means that you work with surgeons, medical oncologists, radiologists, as well as many other physicians to try to figure out what is the best treatment option available for the patient from all of the different options that are out there. You will have long and short-term patient follow-up. This means that you may be seeing patients for just a few days, perhaps for an emergency palliative treatment, or you may be seeing them for many months and many years. So maybe you treat a patient for their cancer initially, you see them in follow-up for 5, 10 plus years, and maybe they have a recurrence of the cancer that you can also treat later. The treatment intent can be definitive, palliative, or benign. This means that you are trying to treat a cancer for quote-unquote cure, and that you are hoping to extend the patient's quantity of life and their quality of life. The treatment may be palliative, where you are focused more on improving quality of life, or you may be treating some benign conditions, and you also may be focused on cosmesis. So for example, the treatment of keloids, or something like heterotopic ossification, or osteoarthritis, which has become a new indication for radiation therapy. The specialty is relatively research-based. Historically, it has had the highest concentration of PhDs and master's trainees. It is very quantitative. It is very much focused on clinical trials and evidence-based medicine in treatment recommendations. The specialty is relatively high-tech. You are using CTs, MRIs, PET scans, etc. You are working with an incredible team of physicists, dosimetrists, etc., in creating a treatment plan that is unique to each patient. Your physical exam is key. You need to know how to diagnose the cancer, stage the cancer, evaluate where the cancer may spread to, and how it is impacting various parts of the body. Your interpretation of images is also key. So you work closely with radiologists, and in some ways you may be able to read images as well as a radiologist can, but you are also not only diagnostic, you have a therapeutic ability. The specialty has a relatively predictable schedule, and so you know when your patient consults are, you know when follow-ups are scheduled, and you can plan your research, education, and the rest of your life around this. You can also evaluate response to therapy. And so if a patient comes to you because they have pain from metastasis and you treat this, they feel better. And you can see this and you can talk to the patient and you may be relieved that you have improved the patient's quality of life. You also work with great colleagues. The specialty is filled with people who want to help others, they want to help patients, they want to work with a great multidisciplinary team. They are fun and friendly. What does the training for a radiation oncologist look like? Well, first, in the US, after completing medical school, you would do a PGY 1 year, which is your prelim or your transitional year. This is sometimes integrated into the residency program, but usually not. And most trainees will do this at the same city as their residency or medical school to avoid multiple moves. Next, you will do 4 years of residency. This is your PGY 2 through 5. This is usually in dedicated blocks, so something like GI, GU, thoracic, etc. Most programs also have a dedicated integrated time of research, which is usually 6 to 12 months. A fellowship is uncommon, but is sometimes available if you wanted to get additional training for brachytherapy, proton therapy, certain advanced technologies. And after completing your training, you have multiple job options. Academics, which has a variable emphasis on clinic research and education. A hospital employed position, which is usually mostly focused on clinical care and not so much research or education. And private practice, which in the US in the 2020s is declining, but still available for certain positions. What is the typical radiation oncology schedule like? So here is a table that breaks down the schedule in terms of clinic, research, education, and service. I should first preface this to say that there is no one schedule that applies to every person, and different people may find different parts of the work exciting to them, and so they may want to preferentially focus on clinical care, that is patient care, or they may want to do more research or more education, or perhaps something like service. And so there's no one schedule that is best for everyone, but the majority of physicians have a clinic-based schedule. So the majority of their time is spent seeing new patient consults. And I would say something like 6 to about 14 consults per week is common. This is very variable and dependent on the complexity of cases, the assistance that you have in clinics. So maybe if you have an advanced practice provider who can help see patients, etc. You're also seeing follow-up patients. You're seeing patients who are undergoing treatment or on treatment visits, OTVs as we call them. You are performing procedures, so stereotactic radiotherapy and brachytherapy. You are contouring cancer, so this is planning the cancer treatment. This is delineating a tumor versus the normal organs on scans. You are then reviewing radiation plans with your dosimetry team and your physics team. You are discussing the care with other involved physicians, so you are not only are you presenting the patient's case at tumor board with surgeons and medical oncologists, you are then also reviewing the radiation therapy plan with your department to make sure that your colleagues agree that this is the ideal treatment. You're spending a lot of time talking to patients, so you may be talking to them face to face, or you may be calling them. You are also dealing with insurance companies, so sometimes you need to get approval for a treatment or prior authorization. And you're doing a lot of charting, documentation, and paperwork. And depending on the type of schedule that you have, the charting and the documentation may actually make up a considerable time of your schedule. So I've heard people quote this as somewhere between 10 and 50% of their schedule that they spend in front of a computer doing this. The next component is research, and this is usually somewhere between 10 and 40% of one's time. So here you're writing and revising research papers or grants, you are writing and running clinical trials, you're working with biostatisticians, you can also be mentoring trainees in their projects, and this also comes with miscellaneous paperwork. Next is education, which is usually less than 10% of time, but it can be more if you're interested in this aspect of your career. So here you are delivering lectures to students, residents, and faculty. You may be involved in your residency program or the medical school clerkship, and you can also be involved in the coordination of the medical school curriculum. You can create patient educational information for your clinic, and you may participate in the community to teach patients about certain aspects of cancer care. Finally, the last bucket is service, and service refers to service to your specialty, your hospital, your the professional organization, etc. So you may have leadership for a particular disease site or a service where, and this has overlap with the clinical care component, and you may be helping to guide the development of a particular program in your hospital. You may be involved in quality assurance throughout the department or through the hospital. You may be interviewing faculty. You may be involved in national and international societies, and this has variability in terms of the commitment and the type of things that you would do. You may be involved in writing guidelines for cancer therapy, and you could also be a journal editor or reviewer or a grant reviewer. What are some of the concerns about radiation oncology cited by prospective applicants? Number one, are there enough jobs? The short answer is yes. The longer answer is that all specialties have cycles. So the available jobs were a concern in around 2016 through about 2020, and the applications to the field declined during this time. However, from about 2021 and on, the market has swung in the other direction, and there are more jobs than applicants. And I would say that this happens to any specialty, and we see it more so in smaller specialties like radiation oncology, where radiation oncologists make up less than 1 or 2% of all physicians in the US. And so I would just say that for any specialty, you must consider the daily work, that is how enjoyable you find the job, the compensation, whether it is direct or indirect compensation, and the location of the position. And so it's rare that you find a specialty where all three of these are an A+, and sometimes you do have to compromise in one of these areas for a position. In 2024, there are about 237 applicants for about 187 positions. And on the right side, we're showing you the statistics from ERAS. This is the U.S. service or organization that evaluates the residency applications, the matches, etc. And so you can see that the number of positions available in the late 2010s was slowly going up, while the number of applicants was slowly going down, although it seems that this trend has now reversed. In 2020, the new graduates were sent a job satisfaction survey. So this is residents who graduated and started their positions, and they were asked to rate their satisfaction with the position that they have accepted, and they were asked to score it in various domains, including the compensation package, the type of location, the geographic region, the job description, the resources and research time allotted, and the opportunities for partnership. This is mostly at a private practice. And you can see that the overwhelming majority of respondents were very satisfied or satisfied with their job. And only a low single-digit % of respondents said that they were very dissatisfied in any one of these fields. And the newest data for 2024 have not been published just yet, but from the recent ASTRO meeting, which occurred in October of 2024, less than about 2 or 3% of respondents are dissatisfied with their job placement. This figure shows the applicants as of October 5th for each ERAS season. So these data are showing you the applicants from 2022 through 2025, and you can see that radiation oncology is now making a large rebound. So the 3-year delta in applications is up almost 50%. The next question that applicants ask is, won't radiation be less needed as other treatments evolve? The short answer is no. The longer answer is that this is very unlikely in the next 50 years. Radiotherapy indications are actually rising. So radiotherapy plays an important role as the backbone of treatment for many cancers, and it's also important when combined with surgery in other cancers. Additionally, radiation for the treatment of metastases has shown an improvement in outcomes in many patients, and it can help keep patients off systemic therapy. So the oligometastatic setting, that is when there are just a few metastases throughout the body, has been recognized over the past few decades, and radiation therapy, specifically with stereotactic body radiation therapy, can be an ablative treatment. That is, we can focus a very high dose of radiation to a metastasis and hopefully kill all the cancer cells in that area. So the chance of that happening is like 95%. And then we can prevent that cancer from growing in that location. And if another metastasis forms, we can do the same thing again. Additionally, surgery can be morbid, it can be not feasible, it can be too difficult for a patient, and it can have similar control as radiation therapy. So an example of this is radiation therapy versus surgery for prostate cancer. We now have multiple randomized trials where the two treatments have been compared, and patients with radiation therapy have equivalent quote-unquote cure rates, but they have much better quality of life, and they are happier with the treatment than they would have been if they had undergone surgery. And next, systemic therapy, that is the use of chemotherapy, immunotherapy, hormones alone, can rarely cure a solid tumor or a cancer alone. So you need some form of local therapy, whether it's radiation therapy or surgery, to achieve a quote-unquote cure. The next question that prospective applicants will ask is, oncology depressing? No, it is not depressing. Remember that most patients diagnosed with cancer will die with their cancer and not of it. Cancer often becomes a chronic condition. It is akin to the treatment of diabetes or hypertension, and sometimes there is a flare-up and you have to treat it, and we do treat it, and the patient goes on with their life. And as radiation oncologists, we can intervene to help improve the length of life and the quality of life related to a patient's cancer. Physicians may also find any specialty frustrating if they feel that they cannot make an impact in patient outcomes, and that sometimes the impact that they want to make is some kind of societal change or some sort of change in the environment that would prevent the patients from arriving to the physician's doorstep. So for example, think of yourself maybe in an ER and you're seeing many patients with a trauma or gunshots. You may be frustrated to see that these patients are arriving to because you want to actually, to prevent them from coming to the ER, you would want to make some kind of change in the community so that the trauma does not occur and that they would not need your services. The next question is, what if I don't like physics? Well, medical physics is an important component of the understanding of radiation therapy. The medical physics curriculum is built into the residency. However, it is a limited component of the day-to-day activities. Medical physicists are involved in your multidisciplinary team, and they are really important team members. They perform very specific activities related to planning of radiation therapy. Learning of radiation-specific physics and its application in radiation therapy can be easier than general physics, as there is a very clear clinical correlate that you can understand. And as with much of medicine, you may just need to lean into a topic to find it fun. So you may not appreciate this sub part of the field, and it may seem intimidating. But once you start to understand that this is a core component of treatment, you may find it really interesting, and you may actually want to learn all about it because it can help your patients. What should you do if you're interested in radiation oncology? Well, the number one piece of advice that I would have for most of your training, and this goes from undergrad to medical school to residency, faculty, etc., is to be kind, hardworking, and prepared, and in that order. And so just do your best, show up every day, and learn as much as you can and be better than yourself in the previous day. And if you do that, you will have success. That's a general piece of advice. What about something that's specific to your timeline? As a first or second year medical student, you can shadow in a department. And please feel free to reach out to either me or to Dr. Campbell for information about rotations in our departments. As a third or fourth year medical student, you can do an elective rotation at your home institution. And then if you apply, I would try to do at least one away rotation, maybe 2 away rotations if you have the time. You probably don't need to do 3, 4, or more for the field, as the 2 rotations will provide you ample experience, and you will also have good letters of recommendation from those institutions. You should also aim to have at least one publication around the time of graduation, preferably in oncology, but this does not have to be the case because you may find out about the field relatively later on in your training. What are some important factors that are cited by program directors when considering applicants to radiation oncology residency? Number 1 is personality. Is this person nice, humble? Are they positive? Do they have good emotional intelligence? Are they genuine? Are they tolerant? And are they multi-dimensional? If you, in your core, are a good human being, you want to help others, you can communicate well with the rest of the team, you will have success in your career. The next is your clinical care, and this is typically evidenced by your medical school grades in your clerkships, that is your 3rd and 4th years, and your dean's letter. Your dean's letter is similar to a summary statement of your entire medical school experience. And so the dean's letter frequently has blurbs that are taken from each one of your rotations to summarize how you did on that rotation and your strengths and weaknesses. The next are reference letters. And so these can include academic radiation oncologists, especially from your home and away programs. These are probably the most important reference letters. Radiation oncology is a relatively small field. There are less than about 2,000 or so academic radiation oncologists throughout the US, and many of them know each other. They've trained with each other. They have seen each other at meetings. And so when we see letters from other people who we know, we take those letters with much consideration, because we know that this person knows the applicant. Other letters that may be important are other academic clinical faculty and a PhD or a research advisor. So if you've worked for many months or years with someone for research, I would have this person write one of your letters. Next is your interest in radiation oncology. So you'd want to do an internal rotation and ideally about 1 or 2 away rotations. Research in radiation oncology is also preferable. The next important factor is grit and drive, and this can be evidenced by performing at a high level in a context-specific manner. The details of this are very much dependent on each person and each applicant, because we all have a different upbringing and we have a different background, and we have a different way of showing our grit and drive. And overall, we want to see a positive career trajectory from wherever you started to wherever you are going. Next, we want to see above average exam scores. Currently, USMLE Step 1 is pass-fail, and so Step 2 has, in some ways, become sort of like Step 1 10 or 15 years ago. And so program directors will evaluate the scores to make sure that the applicant is above average compared to their class. Next is the appearance and the professional dress code. So you want to look nice on your rotations. And I could give a whole separate discussion about this, and so we'll save that for another talk. Next is your research. So if you have dedicated time or a PhD, research is expected. You really should have ideally at least one publication, probably multiple publications, especially if you took a gap year or a research year. If the trainee has not had dedicated time, then ideally we want to see initiative to seek out research projects, and ideally you want to have at least one first author presentation or publication. And finally, your personal statement. Just try to minimize the syntax, the spelling, and the grammatical errors. And don't use AI to write your statement, and don't be overly dramatic. If you found this presentation helpful, we would appreciate it if you could scan this QR code and give us a rating. We look forward to seeing your feedback, and we will adapt the presentation in the future, and we'll make additional presentations that will help other trainees in their medical school experience and in their career.